Hello and welcome back to the Wellbe podcast, a weekly series designed to help you learn, expand what you thought was possible, and become as empowered as you can possibly be in your health. I'm your host, Nolan-Smith, a board-certified holistic patient advocate and the founder of Wellbe. And today I'm bringing you a brand new episode all about midwives or midwifery care, what they actually do versus a traditional OBGYN, the different types of midwives, the surprising benefits of working with a midwife for mother and for baby, and much, much more. Before we jump in, I want to give a shout out to Liz Finn, or as she is known, who wrote a review of the podcast that said, "I love this podcast. Great information in an easy to understand, digestible format. Listening to a 20-minute episode on a topic equals what would have taken hours of digging through articles online." I totally agree, Liz Finn. So thank you for recognizing that. We pour so much research into these little episodes that are generally 20 to 25 minutes long, and we think help people understand a topic so much more than doing hours and hours of research online. If you're listening, email hello@getwellbe.com, and my team is going to send you a special gift in gratitude for leaving a review of the podcast. If you would like a shout out from me or a chance to win a gift from Wellbe, make sure you leave a review wherever you listen to podcasts. You don't even have to stop listening to this episode right now. You can scroll down on the Wellbe podcast page in your app, click write a review, give us a few stars and a few words, and then press submit in the top right-hand corner. And boom, you're done. It's super fast and easy, but actually very important for any podcast. So thank you for doing that now. All right, now, when I found out I was pregnant in January, I began researching all of the different options and learned quite a bit. So I wanted to share not only what I learned, but also what my experience has been working first with an OBGYN for the first trimester in Florida, and then 2 different midwife practices throughout my pregnancy in Connecticut. When any woman becomes pregnant, she's suddenly faced with an overwhelming amount of decisions. I know that was certainly my experience. One decision that's often completely overlooked is the question of who will deliver her baby. The vast majority of American women take it as a given that an OBGYN will attend their labor and delivery and never really consider the other equally viable option, which is a midwife or midwifery care. This is likely because women and couples have untrue assumptions and unanswered questions about midwives. At the most general level, a midwife attends a labor and helps women deliver babies just like an OBGYN does. There's a common misconception that midwives are equivalent to doulas, but while they're both important services, they are fundamentally different. A doula is essentially a childbirth coach, providing things like emotional support, patient advocacy, and natural pain management, but is not qualified to offer any medical services. A midwife, on the other hand, is a healthcare provider who can deliver babies and provide other medical care for mothers and babies. The main difference between OBGYNs and midwives begins with their respective attitudes towards pregnancy. Conventional OBGYNs tend to view pregnancy and labor as medical conditions, similar to any other chronic condition that must be managed. They're on the lookout for symptoms and abnormalities that need to be treated and are quick to use medical interventions when one arises. Midwifery care, on the other hand, views pregnancy and labor as normal and healthy life processes and only uses medical interventions when absolutely necessary. Their guiding philosophy is nicely summarized in the phrase low-tech, high-touch, which is often used to describe midwifery care. Midwives take a holistic view of women, considering the totality of their physical and mental health rather than just the numbers on her chart. They aim to give women ownership of the pregnancy process by sharing decision-making and ensuring that she feels autonomy over her own body. It's likely because of this fundamentally different outlook that midwives are less likely than OBGYNs to use medical interventions like epidurals and episiotomies, which is when they actually make a cut, and then instrument deliveries like using forceps. I started out my pregnancy in a rented bungalow with my husband in Key West, Florida, where we decided to spend 6 weeks to escape the Connecticut winter. We arrived in Florida December 30th. I found out I was pregnant December 31st, New Year's Eve. And it turns out that the Florida Keys have very few options for prenatal care. I ended up having to have a friend of a friend ask her OBGYN who had delivered her baby in Miami to take me on as a patient, even though she knew I would most likely not be delivering with her. She luckily agreed, and my husband and I drove 4 hours from Key West to Miami for our first appointment with her when I was 9 weeks pregnant. Normally, you're advised to have your first appointment and your first ultrasound around the 8-week mark. Given my work and understanding of the conventional medical system, I wasn't expecting this experience to be incredibly holistic, but at this point I was pretty desperate. But I at least expected that I'd be given a packet on what to eat, what over-the-counter medications I had to avoid and which ones were okay, what exercises were good for each trimester, what teas and supplements were okay and which ones were not. And the only guidance, it turned out, that I was given was not to eat too much high-mercury fish like tuna or unpasteurized cheese, but that everything else I'd heard, especially about deli meats, wasn't true and that they were fine to eat. There was a long pause as I was expecting the doctor to go on to the rest of the guidance, but that was it. Overall, though, she was a very caring doctor who listened to me, and her staff was responsive and helpful, and I enjoyed working with her. When it came time for us to head back to Connecticut, I was entering my second trimester and wanted to find a midwifery practice to work with in the hopes that it would be a bit more holistic. I found a notable academic medical center in New Haven, that I will not name, that had a midwifery center. And I thought that was perfect because I would be able to deliver at a quote-unquote really good hospital close to a very famous and notable children's hospital, but still receive more holistic care. When I went for my first appointment, it felt like a factory. There was nothing about the guidance and the appointment that seemed more holistic than my OBGYN experience had been in Miami. The midwife didn't review my chart. She wasn't listening to what I was saying. She wouldn't order a test that I asked for because of following some CDC policy. The entire experience made me feel 2 inches tall, like I had no rights or voice in my pregnancy experience, and that I wasn't going to get anything I needed or wanted in the coming months. And I'm a board-certified patient advocate, so this was really hard for me to swallow. Just like I advise my private clients and everyone who listens to this podcast, I had to step into the CEO of my health role. Would a CEO reward this kind of treatment with her business and her dollars? Did I feel empowered? Did I effectively advocate for myself? The answer to all those questions was no. So I went back to the drawing board and started looking for a new midwifery practice. I learned of one that was a little further than New Haven, but still doable, and I set up a virtual consultation. The midwife who talked to me did not rush me asking questions. She did not make me feel stupid about the questions I asked. She understood that I was a patient advocate and would be very thorough in my evaluation of the practice before I decided to work with them. And most importantly, she made me feel like this was really going to be a partnership. Her and the other few midwives in her smaller practice were going to give me options throughout my pregnancy and delivery, and then ultimately I would make informed decisions that felt right for me and my baby. At the time of recording this, I haven't gone into labor, so I can't speak to that experience with them, but I can say at each pregnancy milestone so far, and I'm just 5 weeks shy of my due date at this point, they explain what the standard of care is and then offer me options and don't judge or dismiss me when I research something and then decide to decline it. Now, let's get back to more concrete info about midwives. What do they actually do? Like other healthcare professionals, midwives must be licensed in order to legally practice. And not only are there a number of different types of midwifery licenses, but the way these licenses are treated also varies from state to state. Though the specifics are variable depending on the license and location, midwives can provide services like prenatal care, labor and delivery support, and newborn care, as well as gynecological exams, family planning, fertility support, breastfeeding care, menopausal management, and more. Midwives who work in a hospital setting, which I'll talk more about in a minute, can refer patients to an anesthesiologist for an epidural, but cannot perform an epidural themselves. This is the case for OBGYNs. Likewise, they can call in a surgeon, who will likely be an OBGYN, to perform a C-section, but are not trained to perform the surgery themselves. Outside of the US and Canada, there is less confusion about what a midwife does. In fact, in certain countries, babies delivered by midwives far outnumber babies delivered by an OBGYN. In the Netherlands, for example, midwives are the default healthcare provider for normal, low-risk pregnancies, And more than half of the births in the UK are attended by midwives. Across the Atlantic, however, it's a different story. The US and Canada have the lowest supply of midwives, with just 12 per 1,000 births, compared to around 50 or 60 midwives per 1,000 births in most other developed countries. In America, only 8% of births are attended by midwives, and most of these still happen in a hospital setting. In fact, a mere 1.5% of U.S. births happen at home, compared to 30% for the Netherlands. There's been a slight upward trend in more natural delivery options in recent years, with midwife use up from 6% in 2005 and out-of-hospital births increasing by 72% from 0.87%, so not even 1%, of births in the U.S. in 2004 to 1.5% in 2014, and that's the latest data we have on that. However, when comparing America's numbers with the rest of the world, as well as our own history, midwifery care used to be the norm here too. This changed in the 1800s as birth became medicalized and male physicians took control of the birth process. It's clear that we've almost fully medicalized and pathologized the natural process of pregnancy, labor, and delivery. To fully understand what a midwife does, it's important to first define the different types of midwives. Just as there are different types of doctors, mental health professionals, nutrition experts, and more, there are several different kinds of midwives, and each offers a unique set of services and expertise. In the U.S., there are 3 professional midwifery credentials, though not all 3 are recognized in every state. In fact, only one type of midwife is legally recognized in all 50 states, the Certified Nurse Midwife, the CNM. All the other types of midwives fall under the umbrella of direct entry midwives, which essentially means that they lack certain specific formal training but have proved their competency in other ways. Most direct entry midwives have overseen hundreds, if not thousands, of births, so they're very experienced but perhaps didn't undergo specific formal training. Now, let's look more closely at each type of midwife that you'd find in the U.S. The first, which I mentioned, Certified Nurse Midwives, the CNM. This is the kind of midwife I am working with currently. These are trained nurses, which is why they are the most widely recognized type of midwife and can offer women the most comprehensive care options. To become a CNM, you must first complete nursing school, then get a master's or doctorate degree in nursing with a specialization in midwifery. Then pass the certification exam administered by the American College of Nurse Midwives. The CNM license is recognized in all 50 states, and CNMs can deliver babies in all settings, from hospitals to birth centers to homes, though the vast majority of them practice in hospitals. Because of their nursing training, CNMs can also write prescriptions for medications. Then we have certified midwives, so just CMs. Because they do not have a background in nursing, certified midwives fall under the category of direct entry midwives. The process to become a CM is nearly identical to the process of becoming a CNM, which is the certified nurse midwife who is a nurse and the kind I'm working with. The only difference being that their undergraduate degree is in a health-related field other than nursing. For instance, someone who earned an undergraduate degree in occupational therapy and then went on to earn a master's degree with a specialty in midwifery and passed the certification exam would be considered a certified midwife, a CM. Only a handful of states recognize the CM license. They are Delaware, Hawaii, Maine, Maryland, New Jersey, New York, Oklahoma, Rhode Island, and Virginia. But in the states where they are recognized, they may write prescriptions and order medical tests and procedures just like a CNM and like all OBGYNs. Then we have certified professional midwives, or CPMs, another example of a direct entry midwife. A CPM attends almost exclusively out-of-hospital births, so births at birthing centers or at home. In fact, 92% of births in a home or birthing center are attended by CPMs. CPM education focuses on hands-on experience with an emphasis on natural childbirth without medical intervention and culminates in a national certifying exam issued by the North American Registry of Midwives. CPMs are licensed to practice in 33 states but cannot prescribe medication and may only practice in birth centers, homes, and private clinics, i.e., not hospitals. Lastly, we have traditional or unlicensed midwives. There's no acronym for this one. These are midwives who haven't pursued any formal certification, whether for religious, philosophical, personal, or practical reasons. Their type and level of training varies, but many practice in indigenous or religious communities, such as the Amish or certain Native American tribes. Many traditional midwives believe that midwifery care is a social contract between the midwife and the pregnant woman, and that it shouldn't be regulated at all. So I've answered one question, what does a midwife do? But that leads to another question, should you choose a midwife over an OBGYN? First off, with the caveat that each pregnancy and the circumstances surrounding it are completely unique, and no decision is right for everyone. The general consensus among reputable organizations is that midwives are the safest choice. The World Health Organization recommends midwives as an evidence-based approach to reducing maternal mortality, i.e. death, and has launched a global effort to increase women's access to midwifery care with the goal of providing the best possible pregnancy services to women everywhere. The United Nations has explicitly declared that the midwives save lives, adding that they avert 2/3 or 66% of all maternal and newborn deaths, and are qualified to provide 87% of all sexual, reproductive, maternal, and newborn health services. And according to the Department of Health in the UK, midwifery care is the safest choice, beating out hospital care, if you can believe that. When you begin to look at the benefits of a midwife, it quickly becomes clear why all of these institutions have reached this conclusion. In paper after paper, the research shows overwhelmingly that midwifery care leads to better outcomes for both mother and baby, not only at the time of delivery, but also with regard to maternal recovery and newborn development. Taken one by one, here are some of the evidence-backed benefits of working with a midwife. Number 1, lower C-section rate. Research has shown that the births attended by midwives are significantly less likely to end in a C-section. In one study, women who gave birth at hospitals with high levels of midwife-attended births, the C-section rate was just 15%, compared to the national average of 30%, which is half. Next, there's a lower risk of an episiotomy, which I talked about. This is an incision made in a woman's perineum during labor, which can lead to painful sex, infection, and an increased risk of severe tearing, among other risks. Research shows that women who give birth with a midwife have a lower incidence of episiotomies. Next, we have a lower risk of tearing. Women who give birth with midwives are less likely to experience a perineal tear than those who deliver with an OBGYN. Then we have lower rate of induced pregnancies. Using a midwife is associated with a reduced rate of labor induction and augmentation techniques, which are used to start or speed up labor. These interventions include the drug Pitocin, artificially breaking a woman's water, and a technique called sweeping the membranes, in which the amniotic sac is manually separated from the uterine lining. Then we have a lower risk of preterm or small for gestational age babies. Research shows that compared to physician care, midwifery care is associated with a lower risk of preterm babies and babies that are small for gestational age, meaning they are smaller than the average baby born at that number of weeks. Then we have reduced maternal and infant mortality or death rates. In a recent review published in the Lancet Medical Journal, researchers estimated that a substantial increase in the amount of midwife-delivered interventions could prevent 41% of maternal deaths, 39% of neonatal deaths, meaning for the infant, and 26% of stillbirths, which is incredible. Lastly, we have better breastfeeding outcomes. Compared to mothers whose births were attended by an OBGYN, mothers who delivered with midwives were twice as likely to breastfeed for at least 6 months. The benefits of a midwife become quite striking when you lay them out side by side. These benefits are particularly important when you consider the alarming rate of birth complications. Every day, approximately 35,000 women will experience birth complications globally, and 900 will die. Given the proven safety and reduced risks associated with midwifery care, it seems that the midwifery model offers a valid path toward lowering these numbers and improving outcomes for mothers and babies worldwide. So if you decide to work with a midwife, what does that actually look like? Where do they practice? Are they for everyone? Are they covered by insurance? So here we go. Where do they practice? Where a midwife practices depends partially on the type of license she has and partially on her own preference. Certified professional midwives, or CPMs, and traditional or unlicensed midwives practice only in out-of-hospital settings like birth centers and homes, while certified midwives, or CMs, and certified nurse midwives, CNMs, which is what I'm working with, may practice in either hospitals or out-of-hospital settings. Note that for CMs, this only applies in the states where their license is recognized. Most CNMs practice in hospitals where they have access to the full range of medical interventions in case they are necessary. Many hospitals work with certified midwives, CMs, or certified nurse midwives, CNMs, either through their own in-house midwifery department or by partnering with individual practitioners or private practices. If you work with a midwife who can practice in all birth settings, it's really your choice where you would like to deliver. Now, are midwives for everyone? The conventional wisdom is that midwives are the safest, best choice for normal, low-risk pregnancies, but that those with high-risk pregnancies should work with a conventional OBGYN. There are a number of reasons that a woman would be considered high risk or that complications would be expected, including age, hypertension, chronic illness, gestational diabetes, obesity, or being pregnant with multiples, i.e. twins, triplets, etc. This is because in many of these cases, C-sections or other medical interventions are likely necessary, or so the conventional medical system believes, which is why it's generally recommended that these women work with an OBGYN. However, some midwives co-manage high-risk pregnancies right alongside OBGYNs, which could be a good option for women with high-risk pregnancies who want to have a low intervention or less medicalized pregnancy while still having a safeguard against complications and an OBGYN on call if it's necessary to perform a C-section. Now, is midwifery care accessible everywhere? In the U.S., the answer to that question is unfortunately no. Because of the state-by-state regulations and licensing requirements, your access to a midwife is greatly dependent on where you live. Many states limit midwifery practices for both CNMs, and those are certified nurses, and CPMs, making it more difficult for midwives to do their jobs. While 23 states do not regulate CPMs at all or provide any avenue for licensure, effectively making it illegal for these midwives to practice. In some states, such as Hawaii, it's prohibitively expensive to obtain a midwifery license, while Delaware has put up so many obstacles to obtaining a CPM license that one hasn't been issued since 2007. In Alabama, the obstacles are so great that there are currently only 19 certified nurse midwives, or CNMs, and 12 CPMs in the entire state. The obstacles to midwifery care are the result of a number of factors, including lobbying efforts by physician OBGYNs to prevent midwives from practicing autonomously. Remember that most doctors get paid based on the medical procedure they perform. So more midwives facilitating natural vaginal births with less C-sections means less take-home pay for the physician. Now, are midwives covered by insurance? As with most things related to health insurance, there's not a simple answer here. Under federal health law, maternity care is required for most health insurance plans. However, this doesn't necessarily mean that midwife services are covered. Some insurers don't cover midwifery services at all, whereas others cover them only if a midwife delivers the baby in a hospital setting. Some plans cover midwife-attended births in hospitals and birthing centers, but virtually no plan covers home births. When midwifery care isn't covered, however, the cost does tend to be lower than the cost of a conventional OBGYN birth. Medical costs vary greatly depending on where you live and what interventions were used during the birth, but on average, midwife-attended births cost around $2,000 less than an OBGYN-attended birth. The cost of an OBGYN-attended birth can range from around $5,000 to $10,000, depending on where you live and the circumstances of your birth and the kind of insurance you have, etc., while midwife-attended births range from about $3,000 to $6,000. So in summary, midwifery care is a centuries-old practice that is used around the world. It's a model that consistently leads to positive outcomes for both mother and baby, but there's an unfortunate amount of misunderstanding and misinformation about what midwives do and why a woman would choose one. Here's what to remember. A midwife is a healthcare professional who provides prenatal care and helps women deliver babies, among other services. Midwives are different from doulas, who are not healthcare professionals, but rather a sort of birth coach. Midwives take a fundamentally different view of pregnancy and birth than an OBGYN, viewing it as a natural and healthy process rather than a medical condition to be managed. They tend to use fewer interventions and opt for more natural approaches wherever possible. Depending on their certification, midwives may provide medical services like writing prescriptions for medications or referrals for medical procedures. However, no level of midwife can perform a surgery, i.e. a C-section. Next, there are a number of different types of midwives, and each has different training and can provide different services. Certified nurse midwives, or CNMs, which is what I'm working with, can provide the most comprehensive services as they are trained nurses who have also completed a graduate degree in midwifery and taken a certifying exam. They are licensed to practice in all 50 U.S. states and can practice in all birth settings. Certified midwives, or CMs, have a degree in a healthcare field other than nursing, as well as a graduate degree in midwifery, and take the same certifying exam as CNMs. They are only recognized in approximately 10 states. Certified professional midwives, or CPMs, practice exclusively in out-of-hospital settings like birth centers and homes, and their training focuses on hands-on experience. CPMs take a different certifying exam than CNMs and CMs, and they are licensed to practice in 33 states. Traditional or unlicensed midwives are midwives who have chosen not to pursue a license for a variety of reasons, and their training varies. There are a number of documented research-backed benefits of working with a midwife over an OBGYN. Midwife-attended births have been associated with a lower risk of C-section, a lower risk of episiotomies, which is an incision, perineal tearing, induced or augmented labor, preterm or small for gestational age babies, and maternal or neonatal, so infant, death, as well as an increased chance of breastfeeding for at least 6 months. Next, midwives practice in a variety of settings. CNMs practice mainly in hospitals, but can also practice at birthing centers or in homes. And then CMs can practice in the same birth settings in the states where they are licensed. And then CPMs can only practice in birth centers or homes, and traditional midwives tend to only practice in homes. Working with a midwife looks different depending on where you live and the specific circumstances of your pregnancy. In general, women with high-risk pregnancies are advised to work with an OBGYN simply because they just assume that they're going to need a C-section, but some midwives co-manage higher-risk pregnancies with OBGYNs, allowing women the chance to get the benefits of working with a midwife while still providing quick and fast access to a surgeon, an OBGYN, who can perform a C-section if needed. Next, whether or not midwifery care is covered by insurance depends on your specific plan. Many plans only cover midwife births that occur in a hospital, while some other plans cover midwife-attended births in birthing centers. Very few plans cover home births. And there you have it. This might be the most information you've ever heard on midwives and midwifery care, but now you are really informed about them in case you are thinking of having a baby and working with a midwife, or you are already in the search for an OBGYN or a midwife, or you have a granddaughter who might be thinking about it, or a friend, or lots of other people in your life that you can share this information with. If you have worked with a midwife, and absolutely no pressure, but if you'd like to share your experience, I'd love to hear it. So head over to the article version of this episode on getwellbe.com and tell me about it in the comments section there. You'll find a link to the article in the show notes. Also, while you're there, become a Wellbe Insider so that you can get all of our latest content, special offers, and personal notes I don't share anywhere else weekly in your inbox. Plus, you'll get a free copy of my audio guide on how to feel the best you've ever felt and heal anything. The 10 things you need to optimize your health and heal any health issue, big or small, naturally. Even if you're the healthiest person out there, I promise you'll learn something you didn't know before that can help you optimize your health. I'll see you back here next week for another episode of the Wellbe podcast. If you haven't already and found this episode helpful or interesting, subscribe to the podcast. This way you'll never miss a new episode and they'll be delivered to you whenever we publish a new one. And please share this episode with family or friends who you think might find it valuable and informative. It means a lot and helps more people find the podcast. If you already have, then thank you so much. I really appreciate it. Once again, this is your host, Adrienne Nolan-Smith, and thanks for listening to the Wellbe podcast.